our purpose in today is to really give you a framework in terms of broad brush strokes as to how to evaluate liver tumors. And then we'll have some practical digital slide examples, both illustrating and then to practice those. But ideally, for practice sake, I think you'd be best off to come back to the digital slides and look at them carefully on your own time, because I don't think we'll have a lot of time to go down into small nuances on a lot of the things. But you'll be able to recognize the common patterns and things where the differential considerations that are common are found, and that will help you to recognize when there are irregularities or things that don't fit into those common areas, and that you'll need to think about more strongly or consider other options. So let's just start and look at the WHO classification. Not terribly complicated, but there's a number of things on here as usual that are very uncommon. We've got the benign side of various adenomas, both hepatocellular and bile duct types. And then these other three things are really quite uncommon in the liver. IPMN and MCN you should be able to recognize because you see them frequently in the pancreas. Adenofibromas, I could not find one in our files. And so you'll have to go to the textbooks there to look for what those things look like. On the malignant side, of course, we have hepatocellular carcinoma as the most frequently encountered lesion. But fortunately for us, this has a number of very interesting variants. We're getting some feedback on somebody, so maybe you might want to just mute your feedback if you're in a group room, and so we need to ask questions or something like that. There are several subtypes of hepatocellular carcinomas that can be quite intriguing and heteromorphous in terms of their grade and so forth, and the overall pattern. So we'll touch on some of those. You've got hepatoblastoma, which is usually a pediatric disorder, and so not seen a lot in adult settings, but I've pulled some from our pediatric files to show. And then you move into the bile duct side of things. Cholangiocarcinoma, of course, is the major differential, and then that, of course, looks a lot like metastatic lesions. And then you've got these mixed entities, combined hepatocellular cholangiocarcinoma, and so-called cholangiocellular carcinoma, which is kind of the other variant along that continuum. Sometimes those get subdivided, but they're also fairly uncommon. The neuroendocrine tumors, we won't spend time on those today, but they're typically classified as they are elsewhere into the 3 grades of well-differentiated tumors, and then large cell versus small cell. And finally, you have mixed neuroendocrine and non-neuroendocrine carcinomas, the so-called minans. Again, uncommon as primary tumors in the liver. So let's begin and just talk about criteria for diagnosis of hepatocellular adenomas. This is a topic that Dr. Loy covered quite nicely in the OSAP talk a few weeks back. But primarily, you're looking at non-cirrhotic liver, and you're looking to see what's not there. In other words, you've got arteries without interlobular bile ducts. And so if you see arteries and veins, but not interlobular bile ducts, think adenoma. And then you can get into the fine points of subclassification. And these are not trivial, and certainly something you need to pay attention to. But this is not going to be something I'm going to focus on today, because Dr. Loy did that recently quite well. But we'll just show you an example here. And because needle biopsies are the challenge here with this lesion, because you don't know if, if you just missed it or something like that. That's why we dotted it over here. So here's our bile duct here. So we can say this part at least is not a hepatic adenoma. But then the rest of the lesion, we might look at an area like this, for example. Don't pixelate on me here, and say, gee, I'm not seeing a bile duct here. I've got a vein, I've got a little arteriole, I'm not seeing a bile duct here. And so seeing that kind of a criterion would begin to make you think that of the possibility that this was an adenoma. And then, so you'd want to look at a few others to see if that was holding true, or if you were just missing it because of sectioning. Looking at another example, this one, a resected one. One of the things about these lesions is that they can be a little bit dicey in terms of the margin. They don't always have a real strikingly clear margin. And sometimes the overlap with focal nodular hyperplasia can be challenging. So for example, looking at this at low magnification, I might think initially about focal nodular hyperplasia because it's quite nodular and it looks like we have some scarring here. Looking down in here, we might ask, well, do we have a lot of bile ductular proliferation in this lesion? And it's sometimes hard to tell whether this is truly bile ductular proliferation or just something like that. But I think in this situation, you're seeing what look like there are bile ducts in here, and that's usually not a feature of an adenoma. So this would give you, yeah, here we see nice little bile duct. So I think in this case, seeing this central scar and this inflammatory process, you should be thinking more towards focal nodular hyperplasia. Here's another example, I think this time illustrating how the margin here again is not particularly sharply defined. So here in the middle of this, we can have these hyalinized fibrotic areas, maybe even sort of infarct-like areas. But as we look at the surrounding vascular structures, again, we're not seeing the bile ductular component. And so this fits well with adenoma, whereas when we get over here to the periphery, maybe into more normal mucosa or more normal parenchyma, you might say, well, gee, we still don't see bile ducts in all of these areas. So for example, here, again, you have a vein, a portal area seemingly, but no evident bile duct. So as I've indicated, the margins on these adenomas sometimes can be very difficult. Seeing fatty change in an adenoma is also possible and shouldn't dissuade you from thinking that it's possibly an adenoma as well. Here's another example you can come back and study. Again, the margin can be very difficult to discern at some points, but this was another example of the adenoma. And in terms of staining, typically you'll use things like beta-catenin. This one is negative. You'll use things like glutamine synthetase. I don't know if this is glutamine synthetase or not. I can't see that or not. This looks like it may be a different control. But again, I'd refer you to Dr. Loi's comments on this topic because he covered this quite nicely in terms of the process. Here's the glutamine synthetase, and we'll just project that here, which shows you this more map-like pattern of glutamine synthetase activity with areas of positivity and broad areas that are negative. Okay, so let's go on then to talk about bile duct adenoma. Bile duct adenomas are usually very small, maximal size up to 1.5 centimeters. And these are usually very simple tubular bile duct type of process without any cystic changes. Helpful fact is that you can have this inflammatory pattern around the periphery, maybe even granulomatous calcification. And that can be very useful if you're looking at a frozen to recognize that and not mistake it for possible desmoplasia or something like that. So here's a fairly nice example. This is a frozen section slide. Some of you may have seen this. We put it in one of our frozen section evaluations not too long ago. partly because it was a pitfall. It was a challenge on surgery. The setting was a patient with pancreatic carcinoma. And as you look at this here, you see there's a little bit of low-grade atypia to some of these cells, not very pronounced, but a little bit of heterogeneity. But the clue is here, look and see, you've got this little peripheral rim of inflammation here. And you shouldn't see that in the typical desmoplastic, metastasis, or at least you shouldn't see it to quite the same degree on the normal liver side of things. Again, rounded contours is more common than wedge-shaped, although they can be slightly irregular. Here, the second example, we've got, you can see here, again, has a little bit of inflammation associated with it, a little bit of proliferation, and very bland cytology on high magnification here, where you've got good fixation to see that these cells have little small nucleoli, but they're not particularly hyperchromatic or pleomorphic. So generally, this is not a problem to distinguish this. Maybe to distinguish it from a von Meyenberg complex occasionally could be a little bit of a difficulty, but that's not a critical distinction, and isn't going to kill the patient or create consternation over a misdiagnosis. Biliary adenofibromas, as I mentioned, are very uncommon. These tend to have tubular structures, microcystic, with eosinophilic debris and bile in them, and some associated spindle cell stroma that may be sort of pleomorphic, sort of phylloides, tumor-like type of stroma. So that's what you're thinking of in terms of biliary adenofibroma. If you see one, I'd love to see it. Be sure to share. IPMNs, essentially identical to what we're seeing in the pancreas, no evidence of ovarian stroma. And of course, these can have dysplasia and potentially even invasion, of course. And the epithelium, as we see elsewhere in the pancreaticobiliary tract, can be variable, either mucinous or oncocytic or even gastric types, where in the pancreas, those have been split off into other classifications, but in the liver, at least under the current WHO, they're still classified here. So here's an example of a essentially probably the simplest of intrahepatic cystic lesions, maybe a biliary cystadenoma. This is not very mucinous here, although it does have mucinous lining, and this even has a little bit of stroma. So maybe this would fit better into the mucinous cystic neoplasm type of category, because we've got a little bit of a more spindle-shaped stroma and suggestion that maybe there's some mucin component here. Again, the distinction between either of these two in the benign phase is not critical. They're both uncommon lesions. Here, I'll show you another example of the papillary mucinous neoplasm with very florid papillarity, obviously, and this is more intestinal type epithelium that shows a degree of dysplasia, because you've got areas where you've lost the cytoplasmic mucin, the nuclei are more stratified and so forth. So it begins to look like, a Pannin 3 rather than the Pannin 1 or something like that. In terms of the degree of dysplasia that we're seeing. And then, of course, with this type of lesion, you want to make sure that you're going to be able to exclude invasive neoplasia. Now, I cheated a little bit. I think this is not actually from within the liver, but I wanted you to be reminded of the morphology that is to be expected with the IPMN type of lesion. Mentioned mucinous cystic neoplasm, also is termed hepatobiliary cystadenoma or cystadenocarcinoma, ovarian type stroma, and maybe dysplasia can be present as well in these lesions, so you want to be sure to sample them. This was interesting to me that sometimes the stroma can actually be luteinized in these lesions, meaning that they could potentially become or be associated with some clinical hormone production abnormalities in terms of, menorrhagia or hirsutization, depending on the hormone that's being produced. Okay, now focal nodular hyperplasia obviously was not in the WHO classification, but it certainly enters into the differential of adenomas and these low-grade lesions. So I thought it would be good to include a few examples. We put one up there with the lesions, the adenomas. Again, like adenomas, this is a non-cirrhotic liver lesion, but does have this central scar. So sometimes it can look like there's kind of cirrhosis. Well, in an otherwise healthy patient, you want to think about this lesion because it's not going to be cirrhosis, it's more likely to be focal nodular hyperplasia. This does have a female predominance, and the vessels can be fairly thick with some degree of fibrointimal changes and so forth. There are variants which have atypia, and certainly steatosis also can be seen in these lesions, oftentimes without any surrounding steatosis. So one of the cases I sent you as a preview for today was the frozen section of this case. And so here's our permanent sections, and the key here is nicely highlighted is these rather odd vessels. Now, here you may say, well, where's the bile ducts? But I think there are a few bile ducts here, so they're kind of hidden under the folds. So this doesn't fit particularly well with an adenoma, and this is the central scarred area with, again, these somewhat odd vessels. Notice here we have a little bit of steatotic change. Sometimes this can be florid, and just, this is the only area that's showing steatosis. Sometimes it's identical to the surrounding tissues. But here you see nicely the nodular architecture. Another thing that I think is helpful in these lesions is that they tend to stand out a little bit, like here, like there's inflammation going on. It may or may not be inflammation, but more likely it's this little bit of bile ductular proliferation that tends to go on in the periphery of these nodular hyperplastic lesions. So if you see this coloration with blue and you're not seeing inflammation, think of focal nodular hyperplasia, because this seems to be a fairly consistent change. Here's another example. Again, you see this sort of vague nodularity. This was one from our files. And as you can see here at low magnification, they tried to embolize this lesion. Here's the procoagulant material in the peripheral vessels. And I want to go on to other things, so I'm not going to go into high power on this one. You can come back and review this one on your own. All right, well, let's go into hepatocellular carcinoma, because this is really where the money is a lot of the time. There are several histologic patterns that we can identify in these. There's the solid pattern, probably the most commonly seen, and this is the one that tends to have the more variable grading type of changes. You can have trabecular patterns or pseudoglandular patterns. And then there's this occasionally identified giant cells or pleomorphic cell type of pattern that's seen in the more anaplastic type of hepatocellular carcinomas. Grading is also an important issue with hepatocellular carcinoma. The WHO recognizes 3 grades, whereas some other authors have recommended 4 grades. As in most schema, the fewer the grades, the more the reproducibility. So, we probably tend to go with 3 grades, well, moderately, and poorly, more than with 4 grades. But you can read about that. And my goal is not to have you become an expert on grading. That can wait for a later time, as I've indicated here. This is the 4-grade system, the Edmondson-Steiner grading. Very well differentiated grade 1, obviously. And the particulars of these grading systems are here. I'm not going to force you to learn this at this point, but you should be aware that this is what it is, and you can use this as a reference if you want to be aware of this matter. I'm not sure that this is board material, so I'm not sure it's even worth spending a lot of time on. But I think this is board material, so I would certainly want you to make sure that you understand and know the distinctions for the fibrolamellar variant of hepatocellular carcinoma. Probably you've encountered this, if you have encountered it, on the pediatric service, because it's much more common in younger patients. There is a fusion gene, and this is considered useful. It is available as a clinically to identify it via send-out testing and so forth. And usually in these patients, there's not a background of liver disease. So if you have a liver mass in a young patient that looks like it's going to be cancer, the clinicians are going to say, well, is it fibrolamellar carcinoma? When it doesn't look like the usual fibrolamellar, then they'll usually want you to send this fusion gene test out to verify or to rule it out. Morphologically, these are generally characterized by very large oncocytic cells with interspersed collagen bundles. Well, that's very easy to say, but maybe a little bit more difficult to identify. So let's take a look. Here's a needle biopsy, and let's see what we've got here that might classify in this category. So we have some fibrous bands here. And of course, this is a rather wrinkly needle biopsy, but I think we can say that these are fairly large cells and that maybe a little bit oncocytic. It's kind of darkly stained. It's not highly pleomorphic, but it's certainly atypical. And so this might come into the consideration. So as you look at this, that should cross your mind, especially if this is a younger patient that fits into those age group categories. Finding necrosis, of course, is possible as well. Now, if most of the time you're going to have to make this diagnosis on the needle biopsies, and that's why I've tried to include these, because once you get a resection specimen, it's much easier. Here's another example, again on needle biopsy. And here I think you can see maybe a little bit more easily because it's cut more cleanly, that these really are very large cells, and they do have this very granular oncocytic type cytoplasm with these associated bands of collagenous tissue. Now you can go down the tubes on this if you don't understand some of the immunohistochemistries that you can observe in these cases. So for example, here is a CK7. Now, usually we do not think about hepatocellular carcinomas as being CK7 positive, but this is the exception. It's nicely positive with CK7, albeit in a somewhat sort of splotchy variable manner, but some of these cells are very strongly positive. So CK7 actually is a helpful clue in making the diagnosis. These cells will also stain with HepPAR, as you see here. Both the normal and the neoplastic tissue is staining positively with this marker. And as well, you can also see some staining with CD68. So this is kind of an unusual phenotype to find in a liver tumor. It's not very many carcinomas that will stain with CD68, but this is a nice example of that. So I've given you some other examples of this in resection specimens to look at as well, and I'll let you come back and take a look at these afterwards. But I think, as you can see, the amount of fibrosis can be variable, but the very large oncocytic type pattern cells, very firm cytoplasm, and usually quite a high degree of pleomorphism in the nuclei with these cellular fibrous bands in between, and essentially no background cirrhosis or background abnormalities of the liver tissue. Note a little bit of vascular anomaly here in this particular case as well. Another example, you can see the nodularity. This may look like cirrhotic liver, but this is actually fibrolamellar carcinoma. And this is in a metastatic site. So heaven forbid that you actually get the metastasis as your primary diagnosis. But here you can see again, it's replicating those features with these very oncocytic, somewhat angulated cells and interspersed collagenous fibrotic tissue. So even in this location, in a metastatic peritoneal nodule, you could identify this as likely fibrolamellar carcinoma. All right, so other variants that you might see besides the sort of the conventional types could include steatohepatic carcinoma, clear cell variants. There's also a chromophobe variant, and so these are kind of finely nuanced. There's a lymphocyte-rich, scarus variant, and then these other additional variants, sometimes with sarcomatous or sarcomatoid changes, rather finely diced. Again, the purpose of this presentation is not to become expert in distinguishing each of these variants, but just to give you an idea and understanding that these variants are out there. And so in a tumor like hepatocellular carcinoma, understanding the number of variants that are available is quite significant. I'm going to jump ahead maybe here, and we can look at one of these variants here. This is sort of a clear cell variant, and you can see it's rather pale compared to the surrounding liver tissue. Here you see, as you look at this, you might go, gee, this could be clear cell renal cell carcinoma or clear cell ovarian type carcinoma with this very, very nice clear cell pattern of differentiation. Not something that we would usually associate with hepatocellular carcinoma unless we were aware of this particular variant. Just to take a look at another example, not of the clear cell variant, we'll just go here. Note that this is a case where we've got multiple nodules. And here this would be more an example of the sort of the trabecular pattern that we discussed earlier with intervening cells. Okay, so put that aside here. Let's go on to just take a look at another example here. Again, this is a situation where it doesn't look like this background liver is particularly cirrhotic. And so looking at this tumor here, let's quickly run the poll here. Let me activate the poll here. Let's see, where's my poll? There it is. What stains would you want to do on this case? All right. So just to make sure you're awake, and some of you are still watching, I'm going to ask you this poll here. So vote for which stains you would do on this particular tumor. Okay, I've only seen a few votes so far. Come on, keep voting. Halfway there. Okay, so HepPAR is by far the most helpful stain here, and I think you've identified that would certainly give you definitely this is a liver tumor, not going to be metastatic renal cell carcinoma. Glypican or arginase could be also helpful. Actually, arginase is the more sensitive liver marker than HepPAR. So if you have it available on your menu, in many cases, that's going to be very useful, perhaps even more useful than HepPAR. CK7 and 20, probably not very helpful unless you're beginning to think about differential consideration of combined hepatocellular biliary carcinomas. And CK20, not even, I'm not sure there's anything that you would think of that would really be mandating that as a useful result. CD34, actually, none of you voted for that. And that is generally most useful in cases of well-differentiated hepatocellular carcinoma, where you're starting to think about the possibility that a lesion may be well-differentiated hepatocellular carcinoma. So I'll let you see everybody's results here. Everybody voted for CK or HepAR1. In terms of evaluating the tumor, reticulin is probably the most useful of those histochemical stains because it can help you to identify that your architecture is that of a cirrhotic, or excuse me, not of a cirrhotic liver, but of a lesion without typical sinusoids or liver cell plates. And so this isn't just fatty tissue or a dysplastic nodule. This has actually become neoplastic. Okay, well, I'm glad you're still awake, and we will go on here and talk about one of the variants that is also included there is a so-called inflammatory variant. And here you see a little bit of that. This is a lesion not perhaps unlike what we see in things like EBV-associated gastric carcinomas and so forth. But just looking at this, you go, wow, this is not the usual hepatocellular carcinoma because we've got all of these lymphocytes here. Am I dealing with a germ cell tumor, or am I dealing with a lymphoepithelial carcinoma from some metastatic site or something like that? But actually recognizing that this variant exists, I think can help you to include hepatocellular carcinoma in your differential diagnosis. Immunohistochemistry on this case here was showing that these are mostly all T cells. I think this was a CD5 stain highlighting these inflammatory cells around the neoplastic hepatocytes here. So this inflammatory variant of hepatocellular carcinoma can also be a significant pitfall. Now notice here, though, that this also highlights that we do have a background of cirrhosis. Certainly with the hepatitis B and C related hepatocellular carcinomas, the inflammation probably plays a role in the pathogenesis of the hepatocellular carcinoma, setting up the milieu for subsequent mutational events that prompt the hepatocellular carcinoma to develop. All right, so we're sort of about halfway through here. I think I'll go on here and just talk a little bit more specifically about the immunohistochemical stains. I mentioned that arginase 1 is the highest sensitivity and specificity, whether it's in cytoplasmic or nuclear stain. Glypican-3 is also fairly high sensitivity, particularly in the poorly differentiated tumors. AFP is of very low value in terms of identifying, or excuse me, in terms of classifying things as hepatocellular carcinoma because of its low sensitivity. Albumin in situ hybridization actually is a fairly useful tool, particularly with identifying intrahepatic cholangiocarcinomas. And so we are getting more and more requests for doing this kind of testing when the differential includes intrahepatic cholangiocarcinoma versus metastatic pancreatico-biliary carcinomas. CK7s are usually negative, and then I've mentioned here that CD34 identifies true endothelial cells, which you do not have in normal liver plates. You have Kupffer cells, but Kupffer cells are not CD34 positive. Okay, so let's just take a nice example. Here's a case that comes to be evaluated, and we've got a tumor here. It looks like it's got maybe some solid areas. There's some intervening glandular components here, small nests, maybe even a little bit of glandular differentiation. This is kind of not really well differentiated. This is a fairly high-grade tumor, probably grade 3 or 4 if we're doing that. And so here is a, let's make sure I've got the right. This is a HepPAR stain, okay? So here is a HepPAR stain, and guess what? It's not positive in all of the tumor, but some of the tumor areas are nicely positive. So it's not staining the biliary component, but not all of the high-grade areas are staining. So you see that there's some variability in terms of staining with this lesion. Another marker that can be of use here, and this is in a metastatic site, I believe, here. Make sure we're looking at the right. This is CK7. So here we're seeing the biliary epithelium light up, but the dysplastic nodules and the hepatocellular carcinoma is staining negatively. Another stain that we did not mention, but you should be aware of as a potential, it's not a frequently used stain, but in some settings, perhaps can be very useful, is this histochemical stain. This is not a mucin stain, but this is in fact a bile stain. And so being able to identify the evidence of production of bile by the tumor cells can be very useful. Now I'm wondering if this got mislabeled because it's not highlighting things very well here, is it? So typically a bile stain will highlight little green dots of bile, and I'm not seeing that very well in this, either in the native parenchyma or the neoplastic cells. So I have used that on occasion, but it has pretty much been supplanted by HepPAR and arginase. This is an example of the reticulin stain and highlights for you the differences that would be expected to be seen on a well-done reticulin stain. Here in the native liver, you can see the reticulin highlights each individual liver cell plates and is present in the basal lamina around the Kupffer cells. When contrast, when we come into the tumor, you can see that here the reticulin is highlighting rounded groups, and it's highlighting the nests of cells rather than the channels per se. And so this is an abnormal architecture, although subtly different, but it is an abnormal architecture that supports a neoplasm. And the reticulin stain is, I think, most useful, like the CD34, in the well-differentiated tumors. With the poorly differentiated high-grade tumors, you're not going to be faced with the problems that you have with that. Okay, so we're going to leave hepatocellular carcinoma and go on to hepatoblastoma. This is a lesion that's usually seen in children less than 6 years old. And it comes in a variety of types, as most of our tumors that we put the blastoma moniker on have. It can have epithelial or mixed epithelial mesenchymal types and various patterns. Again, the purpose of my lecture today is not to make you aware or an expert in these classification and areas. I'm working with Dr. Yu to maybe put together a teaching group on these type of cells, and we put on Path Presenter. But just be aware that these are the patterns you can see and so forth. So I gave you this case to evaluate. or to sort of pique your interest. This is obviously, if you were thinking adults, you were probably confused, but if you were thinking a child, well, you'd see here that you've got pretty much an immature epithelial predominant neoplasm, very solid trabecular type of growth, a few nucleoli, a little bit of maybe sinusoidal type of pattern, no stromal element identified in this. And so in the pediatric age group, a tumor like this, you would be thinking of hepatoblastoma, or you could be thinking of a blastoma from another organ, pancreaticoblastoma, if you're in the pancreas or something of that sort. Here's an example of a resection specimen. And you can see here, this is a nice illustration of the lobulated pattern, the small blue cells with a modest amount of cytoplasm, very small nested groupings in this lesion with fairly high grade malignant type cells, immature appearing. This other example here will do, I think has a little bit more little different pattern with these more dilated spaces filled with sort of bloody fluid, bounded nodular areas, not particularly prominent stroma, again showing the same type of cells, very immature cells with a modest amount of cytoplasm. Some necrosis can be seen in these tumors, and hemorrhage could be seen leading to hemosiderin deposition and so forth as they develop. So that covers the main pediatric tumor of concern in this population. Let's go on and talk about combined hepatocellular and cholangiocarcinoma, sort of beginning to bridge the gap between hepatocellular and cholangiocarcinoma. Now, this is an H&E based diagnosis. So this is not something where you have to have the immunohistochemical changes seen, but you have the morphologic features where you have clearly hepatocyte, oncocytic type cells, and biliary small glandular cells in the same tumor. Immunohistochemistry can be supportive, but essentially you're just looking at a tumor like we have in other areas where you've got sort of divergent differentiation coming out of the same neoplasm. And the risk factors with this tumor appear to be the same as with hepatocellular carcinoma, viral, alcohol, non-steatotic hepatitis, non-alcoholic steatotic hepatitis. So probably the pathogenesis is the same, just the stage or the stem cell that's involved in terms of the oncogenesis is probably the differentiating factor. So this is a nice example that illustrates the tumor with both of these morphologies. And so as we look at this, we see, well, here we have some solid tumor here, and then right next to it here, we have this very sclerotic pattern with small glands that looks like cholangiocarcinoma, very sclerotic pattern, not high-grade malignancy, but clearly malignant glands, high NC ratio, crowding, and so forth with this sclerotic background. So if you just had the biopsy of this, you'd say, cholangiocarcinoma, that's a characteristic pattern. Whereas if you just had the biopsy of this, you'd say, well, we have a solid tumor, we have somewhat trabecular growth, it's high grade. I mean, this looks a little bit like those hepatoblastomas that we just looked at in the pediatric age group. So you could say, well, this could be a hepatocellular carcinoma. So that's part of one of the ways that this lesion can present. Another variant on this, maybe less obvious, here, in this case, a nodular area, clear, solid areas, but a few areas show a little bit more glandular differentiation and pattern. Actually, I think this one devolved on some other features as well. I think some of these clear cell areas and a little bit of CK7 positivity immunohistochemically on this lesion. So let's go on to cholangiocarcinoma. This is obviously derived from the intrahepatic biliary tree, and that can be either from large ducts or small ducts. We've seen the dense fibrostroma in the cholangio component of the combined HCC-cholangiocarcinoma. And in this situation, because this lesion mimics metastatic neoplasia from the pancreas, which is much more frequent than cholangiocarcinoma primary in the liver, doing the history or doing the albumin ISH needs to be done to sort of verify that you are dealing with a primary cholangiocarcinoma. This does have an association with a chronic inflammation secondary to Clonorchis sinensis and other liver flukes, and tends to follow the same pathogenetic pathway in terms of SMAD4 and TP53 that biliary type carcinomas in the pancreas do. In contrast, the non-fluke cases more commonly have BAP1 and IDH1 or 2 mutations as the inciting factor. I can see many a board question written out of these two little trivial items here, so be forewarned. So here's an example taken from a liver needle biopsy of what we might see in this kind of a scenario. So here we see some normal liver parenchyma here, getting our baseline, some normal bile ducts, and here's our tumor. Now, this does not have the sclerotic collagenized background. This is a more nested pattern with big plump cells, almost solid. So this might look almost more like metastatic breast cancer than cholangiocarcinoma as a first-time diagnosis. Let's see if we've got some other areas of tumor here. Down here, I think we may have a little bit more. So here we see a little bit more of this tumor here involving invading into the hepatic parenchyma. And you can see even here we have a little bit of mucin in some of these cells as well. So that sclerotic background, while it's the norm, it's not universal. And so considering other possibilities is important. Here's more of a resected specimen. I think this is actually maybe from an extrahepatic cholangiocarcinoma. You can see broad zones of necrosis, but this is the more typical pattern of a very fibrotic, sclerotic pattern with these small racemose type glands amidst the stroma. And so that's, again, a little bit of mucin in some of the cells would be more typical. In terms of immunohistochemistry, let's look at this case. And here we see, a background of cirrhosis. And here's our tumor, this more pale area. Again, we're seeing this sort of wildly configured small glandular pattern in some areas, and the more solid, pseudo-solid nested pattern here in these other areas. Kind of a low-grade neoplastic appearance, fairly uniform rounded cells, prominent nucleoli, a little bit of vesicular chromatin pattern. So the immunohistochemical pattern that we would associate with this is this pattern. This is, as you can see, not Hepar. This is CK7, and it stains these cells quite nicely. They highlight very, very easily with CK7, and you have the internal control of the normal biliary epithelium as your internal control. In contrast, looking at the HepPAR, we see obviously the tumor is negative, surrounding cirrhotic liver, nicely positive. Oh, I think this is the CK7 again. I got that in here twice, and that twice as well. I think that was the arginase. And here is a little bit of weak positivity. This is the CK7. I'm not sure I buy that as the CK7. All right, well, let's go on. We're going to, I mentioned the neuroendocrine tumors as a possibility. The criteria for these is, of course, similar to what we see elsewhere in terms of grading on the well-differentiated tumors. However, we should note that a primary neuroendocrine tumor in the liver is really quite uncommon, but it will look identical to what you see elsewhere. And so your first consideration when you see a biopsy from the liver that looks like a well-differentiated neuroendocrine tumor is make sure you know the history. Make sure you know whether or not there's a tumor elsewhere. Neuroendocrine carcinomas, again, very uncommon. These will usually have an elevated serum marker, either NSE or chromogranin, and normal AFP. And these patients may have some evidence of hormonal production in terms of clinical serotonin type scenario with diarrhea or other intestinal tract. All right, we mentioned the neuroendocrine carcinoma. So let's go on to some of the less common, sort of wrap this up with some of the stromal or less frequently encountered lesions, both benign and malignant. These are lesions which are encountered quite unusually, or not quite uncommonly in the liver, but they do occur there, so it's important to recognize these as possibilities. Again, not expecting that you will have mastered the diagnosis from reviewing these, but I have given you a couple of examples. So here first, certainly the most frequently encountered lesion in the liver is the hemangioma, and yet it's very infrequently biopsied because the radiologists are very good at recognizing it. This is what it looks like histologically, a nice cavernous appearance. These will have a different CT vascular phase appearance than other lesions. And you can see how nicely these dilated vessels are interspersed with normal hepatocyte lobules in between. This lesion, more uncommon, may involve multiple sites in the liver as well as elsewhere. This is the epithelioid hemangioendothelioma. And because this lesion doesn't really look like a vascular lesion, I think you should come back and study these lesions this fairly carefully, because should you get a needle biopsy of this, it could be quite challenging. I didn't have a needle biopsy case, but here you can see, gee, this looks just like a dense stromal scar. You know, you're not seeing an endothelial component here. You're seeing a little bit of inflammation surrounding these areas of residual hepatocytic cells and bile ducts and so forth. Just seeing this sort of stromal appearance. So how does this turn into epithelioid hemangioendothelioma? Well, there are a few epithelioid cells in here, and you just sort of have to realize that this is one of the appearances of that morphologic lesion. So here's an example, lumen-like spaces and somewhat epithelioid cells with a lot of surrounding spindle-shaped stroma and sclerosis. So this might be confused for, cholangiocarcinoma or something like that. And you'd want to make sure that you recognize the importance of the possibility of this lesion when you're considering that differential. Here's another example. I think this is from the same lesion. You can see the nodularity of it. And of course, because this lesion can affect liver, bones, other sites, this is a challenging treatment decision, either in terms of resection or therapy, because of its behavior. So this is not a diagnosis that you want to miss if you're getting a needle biopsy of something because of the possibility. And hopefully they'll give you that history that there may be other sites or other organs involved. Another example, again, another slide, I think from this same case. So it's been well studied. So here's a nice little lesion, a similar sort of situation, and I gave you this in your preview slides as well. Again, it looks like a vascularized lesion. And this is a child, this is a 6-month-old child. And he has multiple nodules with this type of appearance. Obviously, we've got very vascular spaces, but not a lot of blood cells in these spaces, interestingly. The endothelial cells look here fairly bland. This is a nice chance to be a hero and make a huge difference in this child's life, rather than calling this a an angiosarcoma. This is an infantile hemangioendothelioma, which is a benign lesion. Some of these lesions, if they're small, they may regress spontaneously. Sometimes, however, there's such a massive flow through these lesions that there's actually a right heart failure because they have high output failure and because of the flow through these lesions. Sometimes they are treating these with propranolol, sometimes with steroids. This case was actually a rather famous case that I published with one of my colleagues in Vietnam that responded to the use of high-dose turmeric or curcumin, which does have a potential vascular agonist role in mediating some of the NF-kappa B markers that may be involved in the pathogenesis with this lesion. So it was a very intriguing experience. Nobody else has caught on to our use of that drug, however. So that gets us to the end here, and I appreciate your attention.